welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP-EMED-PRN. And for PRN members, slides can be found under the Libraries and Trees section of the ACCP Communities website.
First, today we have Katie Marrison, who is a PGY2 EM resident at Southwest General. She will be presenting a journal club on balanced crystalloids versus normal saline in adults with diabetic ketoacidosis in the emergency department, a pilot randomized control trial. Thank you. So Katie, you can take it away.
So objectives today is just to review the pathophysiology and the current guidelines for management of diabetic ketoacidosis or DKA, to evaluate some of the pre-existing literature comparing different IV fluids for the treatment of DKA, and then to discuss the outcomes, strengths, and limitations of the BRISK-ED trial and how that might apply to practice in the future. I have some abbreviations listed here in case anyone needs to refer back. I think most people should be familiar with most of these. So to start off with, the epidemiology and the burden of disease. So about 14% of all hospital admissions of diabetic patients are specifically related to DKA. And that adds up to an estimated $11.5 million annually. And that was in 2022 on diabetes visits to the ED. And that's related to hyperglycemic crises specifically. Of those 267,000 visits, approximately 240,000 or 85% of these were admitted. The mortality rate is quite low when appropriate care is able to be given. So the rate in the US in 2017 was approximately 0.4%. So again, really good recovery here as long as we're able to treat these patients promptly and effectively. Getting into the pathophysiology of DKA a little bit, there definitely could be a lot more arrows and connections on this slide. Everything is pretty interconnected, but just to kind of simplify things here. So we have three kind of main contributing factors. So first being our relative or absolute insulin deficiency. So relative insulin deficiency in type 2 or absolute in type 1, leading to impaired glucose transport that leads to our increased serum glucose. Next, we have physiological stress. So most often this is some sort of illness, but this could also be triggered by like a cardiac or a neurological event. Many times these triggers do occur along with insulin non-adherence. So that's where the kind of relative or absolute insulin deficiency comes back in. But in response to physiological stress, we have an increased release of catecholamines and glucagon that causes a further increase in our serum glucose. As part of that stress, we also have an increased demand for alternative energy sources since we're not able to use glucose effectively. So this leads to the lipolysis of fats into free fatty acids for energy. And the oxidation of those free fatty acids is what releases those acidic ketone bodies, causing the diabetic ketoacidosis. All of the factors contributing to elevated serum glucose then further worsens the situation by causing glycosuria and water losses, leading to dehydration, further electrolyte abnormalities. So really all of these things put together are what cause the constellation of symptoms and signs that we see in DKA patients. To differentiate from like mild, moderate, and severe DKA is differentiated based on the anion gap, the bicarb, and the pH. So typically blood glucose in these patients is going to be higher than 250, often much higher. However, about 10% of cases are considered euglycemic with glucoses less than 250. That does tend to be associated with SGLT2 inhibitor use. So that's something to pay attention to if it's on their medical history, if this is something you might be suspecting in your patients. In general, the higher the anion gap, the lower the pH, the more severe the DKA is going to be. In general, serum potassium will also be elevated, although the extent of that elevation can vary a little bit. And serum and urine ketones will be positive by partway through this disease course for urine ketones, and they should be present in serum pretty quickly. Patients often present with recent onset of polyuria, polydipsia, nausea and vomiting, or weakness. They may have fruity smelling breath or those small respirations where they're really trying to breathe off the acid. Most of the time, these patients do present with an altered mental status. So this could be anything from mild confusion to complete stupor or unresponsiveness. You can also see some hypotension, some tachycardia, typically in these patients as well. So the main kind of pillars of our treatment here are to correct the dehydration, correct hyperglycemia, and correct those electrolyte imbalances, as well as addressing whatever that kind of triggering or precipitating factor was. So whether that's an infection, a cardiac event, or whether we need to talk about insulin adherence with our patients. Dehydration is addressed with rapid IV fluid resuscitation. Any patients with severe hypovolemia should have fluid boluses given at 1,000 mLs an hour. In more mild dehydration, you can assess the corrected serum sodium and use that to help guide both your choice of fluid and the rate that you would administer that fluid at. When blood glucose reaches 200 or less, you would then change fluids to include dextrose to make sure that we maintain their blood glucose and run those at 150 to 250 per hour. Obviously, throughout this, we're providing hemodynamic monitoring and hemodynamic support as needed if the patient is experiencing shock. Hyperglycemia is addressed with an IV infusion of regular insulin. Typically, this is a 0.1 unit per kilo bolus followed by a 0.1 unit per kilo per hour continuous infusion, but some sites will just use a straight rate infusion right from the start. Typically, this is adjusted later on, more so by our ICU colleagues to maintain their blood glucose between 150 and 200. And once their blood glucose and pH are normalizing, you can consider transitioning to sub-Q insulin, continuing that IV insulin for a couple hours after administration to allow time for it to absorb. The most common electrolyte imbalances are related to bicarb and potassium. So bicarb is not specifically recommended unless the pH is less than 6.9, so a really severe acidosis. If pH is less than 6.9, we would give 100 milliequivalents in sterile water along with potassium to those patients. As we infuse the insulin, we are also expecting an influx of potassium into our cells, so therefore a drop in our serum potassium. So there's instructions there based on the potassium level of how much insulin, how much potassium needs to be given to help make sure that we're maintaining their potassium appropriately. Typically, we're going to monitor these electrolytes every 2 hours until the pH is greater than 7, and then you could potentially space them out a little bit until the DKA is resolved and the patient is able to kind of eat normally and is clinically well again. So now that we've talked a little bit about the general treatment, I'd like to get into some of the previous studies that have compared fluids for the treatment of DKA. So I was able to identify basically 3 studies similar to this study that were comparing some sort of balanced crystalloid solution with normal saline. That would be a study by Van Ziel and colleagues in 2012, a study by Self and colleagues in 2020, and a study by Ramanan and colleagues in 2021. And I will get into each of these in a little bit more detail. So the Van Ziel study in 2012, titled Fluid Management in Diabetic Acidosis, compared Ringer's lactate versus normal saline. This was a parallel arm, double-blinded, randomized controlled trial of adults presenting with DKA. This was at 2 large hospitals as a part of one institution. Patients were included so long as they had a pH greater than 6.9, a blood glucose greater than 235, and had positive urine ketones. They did have to be alert enough to consent for themselves, and they had to have been given less than a liter of fluids prior to randomization into the study. They did exclude, again, those patients with altered mental status or patients who had already received a large amount of fluids prior to randomization, such that they couldn't dictate which fluids were given. The primary outcome they evaluated here was the time between presentation to the emergency department and resolution of DKA, defined by those ADA criteria. So the time in minutes to pH normalization, defined as a pH of 7.32, the median time was about 683 minutes in the saline group versus 540 in the LR group. That was not a significant finding. However, you can see there's definitely some good overlap in our confidence intervals and things, so not a significant difference in that time. However, we did see a significant difference in the time to blood glucose normalization in this study, defined as less than 250. The median time in minutes was 300 hours in the saline group versus 410 in the LR group, so definitely a little bit of an improvement in our saline group in this study in particular. And the time to resolution of DKA overall was also not a significant finding, with a pretty similar time to resolution there. So the authors concluded that the study failed to demonstrate any superior time to resolution of DKA using LR versus NS for fluid resuscitation. Self and colleagues in 2020 conducted a subgroup analysis of previously reported trials, being the SALT-ED and the SMART trial. This was a post hoc analysis where they took out adults presenting to the ED with DKA from these studies. Included patients with an elevated anion gap, low bicarb, and an elevated blood glucose. They did exclude patients that ended up in their neuro or cardiac ICUs or that were transferred to an outside hospital for further care. Their primary outcome was also the time between that ED presentation and the resolution of DKA. So here we can see that the time in hours to resolution of DKA was a little bit shorter in our balanced crystalloid group as compared to the saline group. The adjusted hazard ratio there was 1.68, and that was a significant finding in this study. The time in hours to discontinuation of the IV insulin infusion, however, was also a little bit shorter in the balanced crystalloid group. So the adjusted hazard ratio here is 1.45, again, a significant finding. So they determined based on their subgroup analyses of these two clustered randomized controlled trials that balanced crystalloids led to a more rapid resolution of DKA than resuscitation with a normal saline in these patients. And the third trial, similar to the one I'm discussing today, is the SCOPE DKA trial by Ramanan and colleagues. They evaluated plasma-lyte 148 chloride, so that's a different, similar balanced crystalloid solution, not exactly LR, but a pretty similar electrolyte content there. This was a cluster crossover open label randomized controlled trial. They included patients 16 and older at 7 Australian hospitals who were either presenting to the ED or admitted to the ICU with severe DKA specifically, which they defined as a pH less than 7.25, a bicarb less than 15, and a blood glucose greater than 250. They did exclude patients if they were previously included in the trial, so they were only allowed to be included once. They excluded patients who had any sort of contraindication to one of the fluids for some reason, or if they had a strong suspicion for diagnosis of HHS as opposed to DKA. Their primary outcome was maybe a little less clinically applicable here, so they evaluated the change in base excess at 48 hours post-ICU admission. They did not find any significant difference in that base excess at 48 hours. However, at 24 hours, they did see a little bit quicker resolution in the NS patients, and that was a significant finding. However, DKA resolution overall at 24 hours was not different between the two groups. So they concluded that for patients with severe DKA, specifically treatment with plasma-lyte as compared to NS may shorten time to resolution of metabolic acidosis. It's a little bit unclear from this study how that might correlate to kind of like clinical and functional outcomes. So with that data, we definitely have some gaps in knowledge. One meta-analysis of these 3 studies suggested that using balanced electrolyte solutions may reduce time to resolution of DKA. All 3 of these studies really did have pretty major limitations. Only one of these 3 used any blinding, and that one that was blinded was stopped early for slow recruitment. The other 2 did have open label designs, so that could introduce some bias for sure. And of those 2 that were open label, one was not powered to detect clinical differences and only included the severe patients, so that 2021 study we just discussed, and one was a post hoc subgroup analysis, so definitely some bias there as well, leaving us with not a very clear recommendation on what type of fluid to use. So currently, our ADA guidelines don't recommend any balanced electrolyte solutions. They are recommending saline, half normal, or a combination with dextrose, depending on the patient status and where we are in treatment. However, there is kind of a suggested or theoretical risk of hyperchloremic acidosis if we're providing fluid resuscitation with normal saline. This is something that's been a little bit controversial, but not very well studied as of yet. So that brings us to the BRISK-ED trial. It was a pilot randomized controlled trial where their primary purpose was to demonstrate the feasibility of a larger trial comparing the balanced fluid boluses with saline boluses for treatment of DKA in the ED. Feasibility outcome they described by recruitment rate. And then they did also provide some efficacy analysis. This was evaluated by time elapsed from the ED presentation to the resolution of DKA, similar to our previous studies. We did choose a superiority margin of 40% reduction in time for this study. This trial, it took place at an academic tertiary care center emergency department in London, Ontario, Canada. That department sees approximately 90,000 ED visits and 130 DKA patients every year. To give you an idea of what their practice setting looks like. Patients were included with elevated blood glucose, plasma bicarb less than 18, and or a blood pH of less than 7.3. They did have to have an elevated anion gap greater than 10, and they had to have some presence of ketones or beta hydroxybutyrate in either the serum or the urine or both. Patients who were initially seen at another ED and then transferred to this department for care. If they received more than a liter of fluids, again, kind of similar to other studies, they were excluded from the trial as they could not be randomized to the correct fluids. They also tried to exclude patients with euglycemic DKA or patients who they confirmed not to meet DKA lab criteria, even if they were initially enrolled in the trial. Interventions here, patients were recruited and randomized 1-to-1 to either LR or NS boluses. The rate and volume were decided per the physician's preference, so not a lot of standardization amongst exactly how much they received. All other standard care was provided per guideline recommendations, and the pharmacy prepared kits of 8 1-liter bags that appeared identically were numbered and covered in like blinding bags to ensure that they had enough fluids available that were appropriately blinded for each patient. The feasibility described by the patient recruitment rate, they had a target recruitment rate of 41.3% of eligible patients to reach the sample size that they had calculated for this pilot study. And the efficacy outcome was, again, the time to DKA resolution. So this was hours elapsed between ED presentation, and they defined resolution as a plasma glucose being normalized, as well as 2 of the following normalized, so the pH, the anion gap, or the bicarbonate. Secondary outcomes here, they did also report on time to insulin infusion discontinuation, hospital and ICU length of stay, in-hospital all-cause mortality, hyper and hypokalemic events outside of the ED, any AKIs or other major adverse kidney events following these treatments. And you can see how they defined our major adverse kidney events there. The groups were fairly similar. The average patient was about 46 years old. The majority of patients were male. About half of patients had type 1 diabetes, a little under half had type 2, and a handful of patients were either new diagnoses or were not documented in the chart. Home, almost 80% of the patients were already on insulin, and about 20% were on some sort of oral hypoglycemic medication. The mean blood pressure was about 135/77, and the mean heart rate was about 110. So you can see pretty similar groups at baseline there. Here we can see kind of the number of patients that received fluids before the study or insulin infusion during this study. So we can see the vast majority of patients did receive insulin. Very few actually received many fluids at all prior to randomization. One place that they do point out a bit of a difference here is in the kind of recovery phase. There were more patients in the LR group than in the NS group that were treated with half normal saline. So that could be introducing a little bit of bias here in this study. The recruitment rate that they were able to achieve was about 87% of the patient approach. So this was 52 of 60 patients that they asked. Their minimum target, again, was only 41%. So that was pretty good outcome as far as the feasibility of recruiting for this study. They didn't have any cases that were unblinded or lost to follow-up. So this really does support the feasibility of the study design overall. One thing that they also noted is that research assistants were only available to enroll patients during the day. There may have been some physician enrollment kind of outside of business hours, but the majority was done by those research assistants. So that could also introduce a little bias just in terms of what time those patients were coming in or who may have screened those patients. So time to DKA resolution in hours here, the median for lactated bringers was 15.7 hours versus normal saline was 12.7 hours. See a little bit more hyperkalemia in our lactated bringers group as opposed to the normal saline group, which is not necessarily unexpected. ICU admission, ED length of stay were not terribly different between the groups. Similar outcomes as far as their secondary outcomes as well. So overall, the authors concluded that the study demonstrated feasibility of a similar future study in a larger population, where they do emphasize that this was not powered to detect a difference in efficacy endpoints, but rather more of a descriptive study to assess for, the applicability of the protocol to future studies. So their data does suggest the time to resolution may be shorter with saline than with balanced crystalloids, but that is obviously yet to be seen in the general population. The strengths and weaknesses, so this was a randomized trial and they did utilize an intention to treat protocol. A very relevant primary endpoint given the purpose of their study was to demonstrate feasibility of their protocol. And they did also choose relevant endpoints for their efficacy measures. Again, this was not powered in this study to detect a difference, but they did, provide that data on appropriate endpoints. We discussed the bias introduced by research assistant availability and by the uneven treatment with half normal saline in the DKA recovery phase. And they did also note that overall in this trial, patients were less ill than in previous trials and perhaps as a result received less fluids overall compared to some of these previous trials. So the takeaways here, this pilot study does support the feasibility of a randomized controlled trial comparing normal saline and LR. Larger sample size would definitely be needed to detect a clinical difference in those efficacy outcomes and really make any sort of concrete recommendation on which is better to use in these patients, given how mixed the data is currently. Their recruitment rate and their data would likely be more robust with cluster randomization, and if they could get EMS involvement in the study and recruitment, that would cut down on patients that had already received too many fluids beforehand and kind of increase their ability to randomize those fluids right from the get-go with each patient. Overall, the protocol and the results may be used to inform trials comparing the safety and efficacy of balanced crystalloids with saline in the treatment of DKA in the emergency department. These are my references, and what questions do we have?
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.